Good afternoon. I'm grateful for this opportunity from Dr. Johari to address you all here. I've been involved in this project at Stanmore over the past 6 years and would like to share our experiences of around 100 cases or so. And the senior author was the developer, and this technology started under his care and hands from the beginning. The first case was implanted way back in November 2009, and since then we have maintained a large database continuing to follow up all these children until their graduation from the Magnetically-driven growing rod program project. So summarizing early onset scoliosis, the primary priority here is to guide the growth of the spine with the age of the child, and also limit any kind of a chest cage deformation which can cause a restrictive lung disease and predispose to what's known as a thoracic insufficiency syndrome. At the same time, create a favorable environment for pulmonary maturation and delay the need for a definitive spinal fusion. An ideal solution in any early onset scoliosis progressive deformity would be intervention which would be a one-off approach, wherein the growth is used to harness the resolution of the deformity and address the limitations of the existing growth guided systems that we have. So in general, until now, at least in the beginning or the end of last decade, has been the conventional growing rods, which used to be inserted by an invasive 1 or 2 incisions, and the children were brought to theaters for regular 4 to 6 monthly lengthenings. And we do know from established biomechanical studies, the number of or the amount of forces that is required for distraction would double by the 4th lengthening, that is around roughly 2 years or so. So it is also increasingly found, at least from the beginning of this decade, that especially for a growing child with an immature central nervous system, repetitive anesthesia is also going to compromise their scholastic development, aptitude, as well as performance when it comes to academics at school, etc. So this is one such paper wherein they report that only 42% of those children who had repetitive anesthesia performed in those scholastic tests as compared to those without early onset scoliosis or repetitive anesthesia. So why is it that we don't do a definitive spinal fusion? It predisposes an individual in having a short trunk, and there is a disproportionate upper segment, lower segment ratio, and it can also predispose to well-established entity, what's known as the crankshaft phenomenon, and especially in very young children, it can also cause cardiopulmonary compromise. This is one such slide from Dr. Harshavardhana, which shows 2 children aged 16, wherein they have disproportionate upper segment, lower segment ratio with reduced chest development that you see in a girl who is seated to the right. So another such publication here wherein it is established that the FVC, that is the forced vital capacity, is reduced to less than 50% in at least 2/3 of children if you were to treat them by a definitive spinal fusion. So this is not an option. So what about pulmonary function? This is something that has received enormous emphasis in the recent years, and this is considered to be the most important or a key factor that is predictive and prognostic of a long-term functional outcome. And this was one of the philosophies that led to the birth of Vector, which was a vertical expandable prosthetic titanium rib that was developed by Dr. Campbell. So thoracic insufficiency syndrome refers to inability of the chest or the thorax or the lungs to facilitate normal breathing in that particular child at rest. So it is primarily divided into, as we see, forced vital capacity, which represents the sprint of respiration, and tidal volume, which is what is present at rest, and we live in this state in 24/7. So coming to the pulmonary function, it's also important to know about volume depletion deformities of the thorax, but time doesn't permit me to cover this at depth, so I'm going to just skip that. It is also increasingly found from the established studies that just a mere reduction in the Cobb angle does not necessarily correlate with an increase in the forced vital capacity. So all this led to the birth of the magnet-driven growing rod, and the disclaimer here is that I have no relationships or conflict of interest, though the senior author does have, and that medicine is an ever-changing field, and the only constant thing that we have is change, and also the fact that we constantly strive towards our own extension. So these magnet-driven growing rods have received the National Institute of Clinical Excellence approval in 2011-2012 following our work, and that was also a pedestal which led to the US FDA approval as well in a couple of years or so later. These are some of the things that the mail or the media tends to report and say about the magnet-driven growing rods from New York as well as from our colleagues in Nottingham. So we have heard enough about magnet-driven growing rods. Now to define what they are, it's a novel implant that is being used especially in a progressive deformity to contain the growth of the curve in an early onset scoliosis, which by definition is a manifestation of a spinal deformity in a child aged less than 10. It is facilitated by a non-invasive outpatient or an office-based lengthening, eliminating the need for a repetitive anesthesia. And we now have 5-year follow-up results of this novel implant, which has undergone transformation from a technological perspective from first to the third generation implant. So this is again a brainchild of Stanmore tumor department, wherein they used to have this such mega prosthesis and self-expanding prosthesis, especially for long bone limb preservation surgeries. And that principle has been extrapolated in creation of a growing rod by import of that technology, though the time here does not permit me to discuss this at length. So in summary, if I were to mention the main difference between the traditional growing rod and a magnet-driven growing rod, as we see there, you have to do every 4 to 6 monthly invasive lengthening under anesthesia, which is eliminated in a magnet-driven growing rod. And the amount of lengthening that you want to do can be controlled by you remotely by using these externally held remote controllers. And there is a digital display which explains or mentions the amount of distraction that you have achieved in that particular outpatient setting. So this is how a magnet-driven growing rod looks. It has a proximal end, the main area or the actuator area, which is this portion of the rod, and the distal end. The proximal end is usually 26 centimeters. The actuator area has to be remaining straight at all times and is approximately 9 centimeters in length and is 10 millimeters in diameter, whereas the distal end is roughly 12 centimeters. A cross-section of a magnet-driven growing rod mentions or rather reveals the actuator area, which houses the magnet as well as a coil mechanism to facilitate non-invasive lengthening. These rods come in 2 different diameters, 4.5 and 5.5 millimeters in terms of the diameter. This is made of titanium. And in addition to this, there is also what's called as a standard rod as an offset rod. This is one of those standard rods, whereas an offset rod would have an actuator at the opposite end, which will help if you have a well-balanced double curve so that the actuator lies against the apex of each of the curves. So that's the principle or the philosophy between having those two rods. So another cross-section of the rod which reveals the lead screw or the coil mechanism with an actuator pin. And as you saw, the handheld external remote controller, when it is pressed and held against that particular area, causes lengthening of the rod. So it has undergone numerous biomechanical testing, and based on various such biomechanical parameters, the safety factor as well as the amount of force that is needed to expand with relation to the body weight of the child, etc., have been computed, and the document has been created by the developer. So what they do recommend is to prefer to use a dual rod wherever possible, and especially in a heavier child, better to use a 5.5 millimeter rod. So our preference on insertion of magnet-driven growing rod is using 2 small incisions, exposing the proximal and the distal end of the spine, and then railroading the rod connecting between these 2 incisions. However, in presence of a kyphotic deformity, a true kyphosis, it's better to do a single long formal incision rather than trying to railroad and going through the thorax or injuring the cardiopulmonary structures. We prefer to have 6 anchors at the proximal end, as well as at least screw construct not less than 4 at the distal end. Especially in neuromuscular deformities, we prefer to go down to the pelvis. So in the proximal anchors, the reason for having 6 anchors is that the topmost or the uppermost instrumented vertebral anchor should always be a TP hook or the transverse process hook, because we believe that biomechanically it exerts some externally directed forces so that with growth there is no medial migration of the pedicle screws and cause compression of the spinal cord at the high thoracic level. And this is primarily influenced by the architecture of Taj Mahal and the importance of the minarets and why they were designed with the 5 to 7 degree outward inclination in an attempt to protect the central dome in an event of any kind of a natural calamity. some of the common myths or truths that you hear about the magnet-driven growing rods are illustrated here, and from here I'll start with some amount of literature as well as our own experiences that we have come across over the past 5 to 6 years. So the key questions that people ask us are, this is just an eye wash and the rod doesn't work, the technology is still not reliable or robust enough, and that the whatever correction that you achieve in terms of coronal correction is at the extent of the sagittal balance, and flat back or hypokyphosis is a result of the correction achieved, and that this is such an expensive implant that it is not worth using. And lastly, whether shingle rod should be used, should not be used, should I listen to what the developer or the implant manufacturer is trying to sell me, and is there truly a pulmonary function improvement with use of these magnet-driven growing rods. So this is one such meta-analysis of all existing or available publications until the end of 2015 that I had undertaken, which reveals that in a set of 73 patients from 5 different studies, there has been a true increase in terms of the T1S1 length gain that has happened by multiple surgeons across the globe, which included United States, United Kingdom, Turkey, and a couple of other centers. So yes, this is a reliable implant, and that despite that increase in the T1S1 length, there was also increase in the thoracic kyphosis by 4.5 degrees, as mentioned in a series of 65 patients from the same series from four such studies. So coming to the cost-effective evaluation, we presented this at the 2016 Prague SRS, wherein it was one of the nominee for a Basic Science Award, wherein at a 5-year period, at least in a United Kingdom healthcare workforce model, these rods and implants are more cost-effective than use of a traditional growing rod. And the key gain, especially in our hands at Stanmore, was found to be not less than that amount. So for the use of single rod and dual rod, is the correction with the dual rod better than a single rod, etc.? So this is one such, again, meta-analysis from the reported studies, wherein we did not find any difference in terms of either T1S1 length gain or correction in scoliosis cob angle between the use of dual or single rods. But however, the area where the dual rods won were that the incidence of rod breakages was lesser with use of dual rods. So this is our own study from the senior author series, which I have been involved with over the past few years, wherein in a series of 34 children who were treated with a mean follow-up of not less than 2 years, of which 9 had a single rod insertion and 24 had a dual rod insertion. With the breakup of those etiologies, this were the rod breakages. As you see there were 3 out of 9 single rods that broke, whereas only 1 amongst the 24 dual rods that broke, amongst which you see the number of graduates as well, which means the children who have grown out and have attained their skeletal maturity in this magnet-driven growing rod program. So this is again a break in the radiological parameters with respect to changes in the cob angle as well as T1S1 length gain between the single as well as dual rods. A couple of quick examples here. Though one may say that dual rods seem to be attractive, single rods do have a role, especially if one has a complex or a rigid multiplanar kyphoscoliotic true deformity, wherein use of a single rod will give a lot of modularity, and dual rods may not be possible to be fitted in for closure without any significant skin pressure effects. So what's about the pulmonary function? What is the truth? So our experience now dates back to only 6 patients who have had a pulmonary function testing done preoperatively 6 months as well as 2 years post-op, especially in children with SMA as well as other syndromic scoliosis. There was a statistically significant improvement in a pulmonary function. But there may be another caveat to this, that how do I differentiate the growth? Because with growth as well, there is a pulmonary function improvement. How do I segregate growth and attribute this improvement in pulmonary function to an implant? So this, in statistical terms, we tend to call as gamma error, though orthopods, as we are much more aware of alpha and beta error, alpha which is a p-value and beta which is a power of the study. We should not forget the gamma error. So this is a box plot of our cases wherein it is showing some statistical improvement. But then, as I said, please take this with a pinch of salt, or please come up with your own independent studies to justify oneself. So this is another interesting case. I just wanted to show this with a minimum 5-year follow-up. So as we notice here, there has been a worsening parasol deformity of the chest in a child with say SMA type 2, that is spinal muscular atrophy, that despite best attempts at maintaining the cob angle from preventing from getting worse or preventing the pelvic obliquity from getting worse, if you were to compare the space available for the lung from the leftmost to the rightmost thing, it is self-explanatory. So magnet-driven growing rods do not attempt or address the chest cage deformations that happen as a part of natural history of certain syndromic scoliosis. Now, what did we learn in this course of 6-year journey with use of this novel implant? Number one, in the first generation implant, the rods did not work, wherein there used to be some kind of a jam or the mechanism for lengthening in a remote control fashion was not happening. As in this case, you see this child who started off with a very minimal kind of a curve in the thoracolumbar region, which has increasingly gotten rigid. And this primarily acted as a tether and was responsible for this deformity and had to be explanted. And secondly, what we also noticed with serial follow-up when we used to see these children every 3 to 4 monthly for in outpatients was that with time there used to be loss of distraction that was achieved. And you will notice that there is a coin, that external magnet that child is wearing, which was an attempt towards maintaining the distraction. So this faulty rod eventually had to be exchanged in this child with neurofibromatosis. And finally, the unique pattern of rod breakages, which made us to go back and do retrieval studies and analysis as to why this was happening. And this again was attributed to a defective welding technology. And finally, the manufacturing process was also changed from pulse laser to continuous wave laser. However, the ideal methodology would be a preparation or a manufacturing of a rod which would eliminate any kind of a stress riser, as any kind of a welding will act as a stress riser. So that was the need for a second generation rod, wherein a keeper plate was introduced, which will act as a blockade and preventing the ratchet from collapsing and loss of length gain. And subsequently, the welding manufacturing was also changed. There were at least 3 or 4 instances wherein we had to insert the rod upside down. If you remember, I mentioned the proximal end is 26 centimeters long, whereas the distal end below the actuator is around 12 centimeters long. So in those cases, we have to remember to turn the external remote controller upside down if you want to distract, so which led us to maintain what we call as a configuration, product configuration chart, so as to guide us as to how to hold this distractor when you are seeing such patients in clinic, so that you don't jam the coil and make this as a working as a tether rather than improving with the curvature on time. So in summary, what we do know, however, is that magnet-driven growing rods is a very promising novel technology, and that the results have been consistent across all spectrum of EOS pathologies, from idiopathic, neuromuscular, syndromic to congenital deformities. However, the best results were seen in syndromic and neuromuscular scoliosis. It was associated, at least based on existing evidence, that there was some improvement in pulmonary function, and that the dual rods minimize the incidence of rod breakages. This is a summary of the first, second, third generation rods. So what you see there is the current third generation rod, which was launched sometime in April, May 2016, a year or so ago, which is purely manufactured by SLS technology, wherein titanium powder is laser sintered around the actuator area. It doesn't have any weld, and it will not break. And the diameter is also thicker by 6 millimeters now instead of the 4.5 and 5.5. So what we need in future is better level of evidence study with at least 1 or 2 level of evidence in order to establish if this is the way forward, and comparing this with other established technologies like Sheila or Webster in order to evaluate the superiority of this system over them in terms of surgical results and outcomes, as well as complication rates. And the results of the current third generation rods is still not known to us. Thank you.
Thank you, Dr. Harshavardhana. It was extremely nice. It was absolutely new for me. And this is, if there are any questions, you can ask for it.
Yeah, The actuator area should not be bent because that would destroy the magnet as well as the coil mechanism. The proximal and the distal end could be contoured depending on the deformity that you have to fit in. Yes.
Since the condition is a multiplanar deformity and your expansion is only in a single plane, as the child grows, do you ever see any complications or do you need any kind of revision ever on the rod itself? Because you're saying it's closed now, you can't open it again. That was one of the key advantages.
So if there is any kind of an anchor dislodgement or a rod breakages which do happen because of the paucity of time I couldn't include, so you just treat it like how you treat in a conventional growing rod. You either change a rod or you extend your instrumentation to include a level below, or you may need to include or go down to the pelvis if there is a developing pelvic obliquity. Yes.
So have you all created a specific group of diseases for which the magnet rod should not be used?
So that is a good question. We do not say that magnet rods could not be used for any particular etiology, but the existing recommendation from NICE, which is a governing body similar to FDA that you have here in the United Kingdom, is that these rods are to be used for children aged less than 10 or those who have a growth potential of at least 3 years. Because at 3 years from our UK healthcare workforce model, it is going to be more cost effective to use these rods as compared to the conventional growing rods. I don't know if I answered your question, but that's the existing.
Like even a condition like SMA, you are happy to use it?
Yes, yes. So especially neuromuscular and syndromic scoliosis is where this is a win-win situation, because in many cases the anesthetists as well as the multidisciplinary pediatricians, they refuse or they rather recommend you to use these rods because repetitive anesthesia every 4 to 6 monthly is associated with high intraoperative stay as well as HDU, ITU stay. So this is a one-off situation which will bail you out.
Thank you.
Thank you.